Hi, everybody. I hope you enjoy our meeting tonight. My name is Alexandre Varela. I'm from Curitiba, south part of Brazil, and I'll try to discuss with you a case we had here a few months ago, and I hope everybody has fun. In order to save my hardware here, which is not very good, I'll turn off my camera, okay? Yeah, you can hear me, but you won't be able to see me. Okay, so there we go. We're going to talk tonight about a young patient who was undergoing a preoperative evaluation. This first appointment was on October 26, 2018. He's a male, was born October 1999, and he went to the doctor seeking an evaluation to perform a septoplasty, completely asymptomatic, no comorbidities, no family history of cardiac or neoplastic disease, emotionally stressed due to college issues, physical active, an narghile smoker eventually, and use some medication, anti-allergic medication due to rhinitis, chronic rhinitis, okay? Physical examination was completely normal also. And if you try to understand this patient using the guideline provided by American family physicians, you see it's a very, very, very low risk. Has no cerebral disease, no congestive heart failure, renal function is normal, there's no diabetics, everything is zero here. And if you go there and check the symptoms or the absence of symptoms, you end up with this guideline here. No electrocardiography is needed. So if you follow the American Family Physicians guideline, and you're going to recommend electrocardiography just for patients high risk. So this patient doesn't need an EKG. But what will your exam routine be? Why do not ask for an EKG, right? What about an echocardiogram? They are innocuous, won't harm. And I'm a cardiologist, so I'll ask. Okay. And he performed electrocardiogram, which is this one. Very naive exam, no alterations, and the QRS are just normal. There was nothing to note about this EKG. You went to a two-dimensional transthoracic echocardiogram on October 29th, and the systolic and diastolic function was normal, and the chambers were normal, but he has a hypertrophic mass at the interventricular septum. The measurements went 55/44. So now, what can I do? Well, that's hypertrophic cardiomyopathy, I would say, right? Well, if we check the guidelines from the European Society of Cardiology, that's not the case. Although hypertrophic cardiomyopathy is defined by the presence of increased left ventricular wall thickness, that's not the case. I mean, I have some septum hypertrophy, but I don't have hypertrophy in the basal segments or even in the posterior or lateral walls. And even the patient being asymptomatic does not confirm the diagnostic hypertrophic cardiomyopathy. And so what will be your next steps? Just, I'm afraid your son has a tumor at his heart is not enough. I have to answer that. So let's talk about a little bit of cardiac tumors. They're being around for a while. The first mention to that was around the Middle Age, so it's not a new thing. But to quote Hofmeier, although the existence of cardiac tumor has been known since the Middle Age, they remain a diagnostic puzzle and a therapeutic challenge. And we'll see that the epidemiology, the clinical presentation, the diagnostic, and the treatment are very challenging as well. They are extremely rare, right? If we can divide it into primary and secondaries, cardiac tumors. The secondary cardiac tumors will be the metastatic one, and the primary, the most majority, about 90%, are benign. The incidence is around 1.380 per 100 million individuals. And the secondary, the metastatic cardiac tumors are much, much more common, and they usually are malignant. So we do have to check this. We do have to understand what's going on with this guy. The clinical presentation may bring some clues. Our patient was asymptomatic, but if the patient is symptomatic, we can go through that and see what type of symptoms they present. They are constitutional, like fever or loss of weight, they have fatigue, or they have some direct effects of cardiac symptoms due to the blood flow obstruction or a valve involvement, or they have some embolic events. So these symptoms must be checked. Our patient did none. And how can we go through this diagnostic approach? Well, 4 questions are to be answered. First of all, age of the patient at the time of the presentation. Our patient was 19 years old. Rhabdomyomas and fibromas are the most common benign cardiac tumors in children. Well, our patient is not exactly a children, isn't it? Epidemiologic likelihood and clinical probability. Well, we're not dealing with a patient with a large ventricle or with an MI that could develop a thrombus, an intracardiac thrombus, right? Our patient is young and is healthy. The location of the tumor, that could help. Well, the echo shows us that the tumor was at the septum. So let's consider right ventricle and left ventricle though. A lot of things could be there. Could be metastasis, as we said, could be fibromas, rhabdomyomas, lipomas. Thrombus, I don't think so. So let's take thrombus out. What we need, our next step, non-invasion tissue characterization. All right, we have to see that in a better way. We have to move forward and try to understand what was that. So to establish the diagnosis, 3 goals should be chased. The presence of the cardiac tumor, we know it's there. The correct location of this mass in relation to the cardiac anatomy. Echo will help, but we need more. And if it's feasible, to determine if the tumor is benign or malignant, right? That's the 1 million question. Obviously, the gold standard is to obtain an histopathologic specimens, but we have a lot of room until we get there. Multimodality imaging may play and plays an important role in defining the etiology of these cases. So let's start with the basics. 2-dimensional transthoracic echocardiography. It allows us to access size, location, mobility, if the pericardium is involved or not, has a good spatial resolution, and helps to understand the behavior of the mass, if it has some obstructions, for instance, if it creates some disturbance in the intracardiac flow. But some limitations are to be noted, right? We can have poor acoustic window and the lack of potential for tissue characterization, which is quite crucial. Well, some work has been done trying to solve this. The group of Dr. Barchita has published a paper using injection of Sonovil, and using that low mechanic index contrast echocardiography, they try to characterize the mass and divide it in 3 types. When we have an absence of contrast suggesting thrombus, when we have a contrast partial, either peripheral or spread, suggesting a mass with low vascularization, or when we have a mass completely contrast, suggesting high vascularization. Okay, so contrast echocardiography allows visualization of mass perfusion, allows us to better differentiation with thrombus, since vascularized masses will enhance with contrast. But is that enough? And is this Sonovil available for everybody or everywhere? I don't think so. So if you go back a little bit and try to move to 1990, Dr. Barbato at Universidade de São Paulo proposed a way to diagnose the masses. So if you look at the location, if this mass has a fixation or not, if the growth, the limits, the texture by the echocardiography, and the density, shape, and other characteristics, we may be able to characterize in a better way this mass, and then think about if it's a thrombus, if it's a tumor, what kind of tumor. Well, our echo shows in October 29th this. Okay, so we have here in the longitudinal parasternal section, and you can appreciate that the mass changes the size is because of the transducer who is being moved to better visualize this mass. Okay, and the length is 5.35 by 4.52. Here in the longitudinal parasternal section, we can see the aortic and mitral valves, and they have no compromise by the mass. And in the right side, we can see a whole picture of the mass in the septum. Diastolic function was preserved by post-Doppler and by tissue Doppler, and there was no gradient in left ventricular outflow tracts. What about MRI? Well, certainly it helps. We can include morphology, dimensions, location, extension, homogeneity, infiltration by the surrounding tissues, and other characteristics that will help us to understand better this mass and try to characterize if it's a mass, a malignant tumor, a benign tumor, or even a non-tumor. T1 weighted and T2 weighted imaging also help us and to understand the vascularity of these masses. And this patient was submitted to MRI on October 31. And what we can see on the left is the mass in the interventricular septum, right here. Okay, And here we can see this huge mass in a fourth chamber with a T1 weighted sequence showing a slightly hyper signal when comparing to the myocardium. Oh. Okay, let's see if it works. Yeah, it does. Here on the left image, we can see the fourth chamber plane showing this mass in the septum, and at the right side, we can see the first path perfusion image showing this very vascularized mass. We can see how profound vascularized it is. So at this point, we have the certainty of a mass in the septum and that it's vascularized. Here, an analog image, we can see clear the mass, right? Okay, sorry about these delays. The system is not working very well. Well, angiotomography was performed at the beginning of November 2018, and besides the presence of this large mass, we can see a very well organized vessel here. It's a branch of the left anterior descending artery, and it goes directly to the mass, and that is the mass, that is the vessel that irrigates the mass. So a PET was done. A PET scan was done in order to evaluate the metabolic activity of this tumor, right? Try to understand if this tumor has some staging for malignancies, if it's primary, if secondary, since he's very well vascularized. And the PET shows an abnormal FDG uptake and no evidence of abnormal FDG accumulation in other organs or structures. It was completely and unique at the septum. So we can see here the whole body, and in a close way, this right at the center of the heart. Okay, so at this point, what we have? We have a cardiac mass that's no thrombus. Okay, is no vegetation, is not a structural disease, is not a secondary tumor, so we don't have to worry about identifying primary malignancies. But we still do not know if it's a primary benign or a primary malignant. And the patient age doesn't help, since it's not pediatric and it's not adult as well. Advanced cardiac imaging modalities were extensively used in this case. We use echocardiography, we don't use 3D, but we use 2D transthoracic, use cardiomagnetic resonance, computer tomography, PET scan, so everything was available, was used. If we look through the 2015 World Health Organization classification of tumors, we can see they are divided in benign, malignant, and this new class, intermediate tumors of uncertainty behavior. Well, looking at these chances here, those diagnostic here, we can take something out, right? Myxomas doesn't look like a myxoma, doesn't behave like a myxoma. Fibroelastomes, paragangliomas, and lipomas are also discarded at this point. So we have rhabdomyomas, fibromas, and sarcomas as the biggest candidates to this guy. So what's next? What would you do? Which way we go? Remember that we need a histopathologic examination. So let's try this. Let's try surgical treatment. Even in our very active centers of cardiac surgery, the cardiac tumors are rare. So this paper published in 2014 put us here with a very, very low incidence of rhabdomyomas, liposarcomas, and rhabdosarcomas. The most majority are myxomas and the malignant or metastases from other tumors. Surgical treatment has some problems, right? The resection can frequently involve a complex reconstruction of the cardiac structure, particularly if this tumor is malignant. And it can compromise a structure that needs to be fixed, and it's turning in a very complex procedure. So this young gentleman went to a surgical treatment. This treatment was performed at a hospital at my city called Instituto de Neurologia e Cardiologia de Curitiba. And they excised this on 6th of August 2019. They opened the right atrium, and through the tricuspid valve, they exposed the tumor. They tried to remove the most part of it, but the papillary muscles of the tricuspid valve were inserted at the tumor region. So they have to resect the tricuspid valve. And this debridement of the septum results in appearance of interventricular communication. So they have to close this communication, and they replace the tricuspid valve by a pericardial bioprosthetic. The procedure went well. The specimen was sent to macroscopy, which indicates negativity for malignancy, and they observed that's a proliferation of highly vascularized heart myocytes. At the histology, we can see these muscles, these myocytes in different directions, and they don't have an organized fashion as we expected for cardiac tissue. And also, we have some fibrous tissue in the middle of this, and a lot of vessels, and those vessels were not mature. Those vessels were inadequate formed. So we end up with this diagnostic of hamartoma of mature cardiac myocytes. Well, cardiac hamartomas, they are not very known. The first citation for that was in 1988, and when a case report was published, and the definition was the hamartoma was due to a composition of mature adipose tissue, blood vessels, and fibrous components. There was no myocardial tissue involved in this cardiac hamartoma. 10 years after that, Burke described hamartoma of mature cardiac myocytes as a mixture of rhabdomyoma and hypertrophic cardiomyopathy. and they considered that a separate entity, and then they published this paper and create this term, hamartoma of mature cardiac myocytes. After that, Philly in 2008 described 8 cases, and he found 7 previously patients with hamartomas. So we have 15 patients described in literature. The previously 7 patients, only one had an age around our patient. We had 4 young, very young children, really, and 2 adults. Those other 8, we still have a very low age, and the septum was mentioned in these 15 cases only 3 times. So hamartoma of mature cardiac myocytes show no predilection for age at the detection. They have a slow growth rate, and their relative size is probably established in uterus. Their prevalence is for the left ventricle, explains the frequency that the occurrence of non-specific EKG abnormalities. Echocardiography, CT images is helpful, visualizing the location of the size of this mass. The vascularity is variable, so angiogram may be difficult to interpret. We have the luck of having this with a very large vessel that we can take a picture of it. And there's no means to establish this diagnosis unless by microscopy. So we cannot say that's a hamartoma before we take it out. Some time passes, and that's the control EKG. It was done 1 month ago. We can see some disturbance, but no blocks. And actually, also the patient was submitted to a transesophageal 3D echo for control, and they found the cardiac chambers were normal. There's no enlargement. The systolic function was okay. There was no decrease in the systolic function. The patch at the ventricular septum was okay, but a small interventricular communication next to the patch was left behind. It's approximately 4 millimeters long. Still have an unusual image in the right ventricle outlet tract, just below the pulmonary valve, measuring 20.7 by 12.3 millimeters. No self-mobility with isoechoic characteristics and well-defined edges. And this mass does not obstruct the right ventricle ejection tract. And the biologic prosthesis in tricuspid position had a usual ultrasound appearance without thickening or any other signs of malfunction. I would like at this point to thank all these people who helped me to put together all these images, and especially to Dr. Rodrigo Rosa, who was our lead echocardiographer and helped me to describe these images, and Dr. Marcelo Zapparoli as well, who is the radiologist who helped me with the PET-CT, the MRI, and the angiotomo, and Dr. Marcela Santos, our pathologist. And I have here a picture of our patient, and he also tattooed a very funny EKG at his left side of the chest. So at this point, I would like to thank you for your patience and for this opportunity. And I'm here to try to discuss this with you.
Wow, wonderful presentation, Alexandre. Excellent, excellent.
I'm sorry about my English, but that's what I can do.
Wonderful, Steve. If you are free to open for questions from the audience.
Yes. Any questions or comments?
It was really a huge challenge for the surgeons, considering that there's a very high risk from an AV block. The involvement of the tricuspid valve. Yeah.
It was a long procedure, took about 6-7 hours, and the most concern was about a total AV block, right? But fortunately, it didn't happen.
Yes, and they couldn't save the tricuspid valve, and the involvement of some coronary arteries either. It was a very well investigated case. Congratulations for you and for your team. Wonderful. Very nice. It's worth to be published. So does anybody in the audience would like to comment, make a comment, or write some questions about the case?
People from Image, please, if you want to recheck the images and make your comments, just let me know. I'll put them again here for you.
I have just a little question, Alex. The MRI didn't see the small mass in the RV outflow tract that the 3D echocardiogram, transesophageal echocardiograms saw recently. So what did you think about the follow-up about considering this mass, this new one?
I think that little mass was observed in this late transesophageal echo was part of the tumor that was not resected. Since the tumor didn't have a very easy to see plan of cleavage, it probably was not totally resected.
Yes. Okay. In the infundibular.
Yeah.
Position. Yes, infundibular part of the third part of the right ventricle. Yes. So is now the patient's doing well and have a real free activity and everything? And
everything, no medication.
And did he got his septum surgery of the rhinoplastic or something like this?
The nasal one now. I think he was afraid of ORs for a while.
So you see how
important
is a complete investigation even in asymptomatic patient. So it was a huge surprise for everyone, I suppose.
Yeah, it was interesting because in the sequence of the images, I didn't mention that, but there was a lack of 1 year between the last image of PET-CT and the procedure, the surgical procedure. During this whole year, this patient went through another 3 or 4 different cardiologists. He seek for an oncology consultation, and he tried to travel to Canada, where he find a surgeon who was willing to operate him, but the cost was very high, and he even tried to make some money during this year to be able to go to Canada, but it didn't work. And he traveled to São Paulo, and he looked for assistance there too, but due to financial issues, he ended up coming back to his his city and operates here.
Very nice, very nice. Steve?
Yeah, other questions or comments from anyone?
The echo people, please help me.
The interpretation is very good. So one of the things that we didn't see, Alex, was the tricuspid flow during the videos that you showed, because if there is an involvement of the tricuspid valve, would have a very nice regurgitant jet, perhaps, to make the surgeon think about it. But anyway, it was a very, very well investigated case. Congratulations again.
Thank you.
If you are free.
Yep.
Yeah, if there's no other questions, we'll just thank everybody for joining us. It was a wonderful presentation.
Thank you.
Yeah.
Thank you, everybody.
Thank you so much. Veronica, do you have anything else?
No, we are quite happy. And perhaps we are going to see everybody again next month in December 10th, yes?
Yes. We'll have a
December 10th,
presentation. Yes.
our next presentation, yes, in the South American chapter.
Yes. Great. Well, thank you everybody for joining, and thank you again for the presentation.
Thank you, Veronica.
Thank
Have
you,
a nice
Alex.
and safe.
Yes. Thank you.
Everybody, thank you.
Bye.